how has the format of the visits that you're having with these patients changed? I'm not sure the setting exactly of the clinic in Chicago that you volunteer at, but has the advent of telehealth been something that's been difficult for patients and clinicians to adopt, or has this been something that some of your colleagues have been sort of waiting for people to push the go button on telehealth and incorporate it into practice more?
Right. So it varies, like all things. Some rheumatologists are very forward thinking with telehealth, and they've been doing this for years. Sometimes even institutional or just long distance across states that don't have access. Those are great places to use telehealth. But by and large, rheumatology is very much an in-person specialty because we need to see patients to do our proper exam. Now, the clinic that I go to, Community Health, is in Ukrainian Village in downtown Chicago. We mostly take care of Spanish and Polish speaking immigrants. And so the challenge there has been these patients don't have video capabilities. So for me, telehealth means a phone call without any video. And I don't think any of us were really used to calling that a patient visit. I mean, certainly you call patients to check on them, but you're not trying to conduct a full visit in that way. And so, I'll be in the room, I have my phone on speaker, and I'll call either the Polish or the Spanish or whichever translator, and then together we call the patient. And then you try to conduct your visit, and what I found is it really is kind of a return to basics. You want to be very, very structured. How are things going today? What's bothering you? How are your medicines? Are you taking them? How are you taking them? Any side effects? And then a full review of systems, including all of those COVID-related questions, but then also the rheumatic review of systems, just to make sure that they're doing well, not having other issues come up. So the challenge has been, through a translator with no video, the physical exam suffers. There's simply not another way to put it. If I can't lay hands on the patient, I can't see, their hands, their joints, have them squeeze things. It's tough. You're going to be a little bit limited, and so you're not going to be making the absolute best decision, but you make the best decision you can make based on the information available. So what I've been doing to kind of mitigate this is I'll alternate. If I saw someone by phone, telehealth only, the next visit I will bring them in person. If I'm getting phone calls or I have concerns about the status of their health or I think their disease is taking a turn for the worse, I will request they come in person. And then also, if I'm seeing a new patient for the first time, I really prefer to see them in person just to get that good baseline exam. I'll give you an example. Just yesterday, I had a patient where the reason for consult was elevated CRP, which is a protein in the blood that can reflect inflammation. And so usually you're kind of thinking, well, do they have an infection? Could they have a malignancy? Do they have a rheumatic disease? But this gentleman comes in the clinic and he's got massive protuberances and enlargements on both elbows and other places. And so it wasn't a consult for high CRP. He had musculoskeletal pain and kind of uncertain masses. And so, we're doing a pretty big workup on him to try to figure this out. But if I had just seen him on the phone, I might have done a very different workup just looking for causes of inflammation. So these are the reasons that, you need to see patients in person every so often, especially when you don't have video capabilities.
Thank you for that. And now, what do you think, staying with in-person practices, what do you think some of the longer lasting impacts of COVID-19 will be on rheumatology practices?
Yeah, so it's a good question. There's one rheumatologist that we talked to, and she actually has an autoimmune disease herself. And so she has gone 100% to telemedicine. She won't do any in person, and she's not planning on opening up her clinic until at least 2021. So we've been probably 10, 11 weeks of kind of virtual, clinics, but she's going to go another 6 to 7 months. And you can understand, if it's your health and you're on, a DMARD or a biologic, and you're going to see 10 to 20 patients in person, that is kind of it's not a calculation you can do in terms of your health and your safety. So, that's one extreme example. I think maybe a more pleasant example is that telehealth will be much more widely accepted after this. When the world returns to normal, whatever that is, whatever that looks like, I hope that insurance companies and billing groups are more amenable to telehealth, and so that maybe patients that we're driving 3 to 4 hours for a rheumatology appointment in the past, maybe they can do every other and do one telehealth, do one in person. They can get the blood work close to home at a local lab. And so I hope that kind of a residual long-term acceptance of telehealth because basically we're all doing this now. There shouldn't be rheumatologists or really many clinicians out there that say, well, I'm totally uncomfortable with telehealth, because we've all been doing it for weeks now. And like a foreign language, there's no better way to learn it than to just be thrust into it, and you have to do it. So the benefit of that is, long term, I think there'll be a much higher rate of acceptance for that part of this, that style of practice.